Good morning, everyone who's here and to everybody who's online. Wanted really to say thank you very much for joining us. And I should tell you that my name is Susie Lessoff. I'm the coordinator of the European Observatory on Health Systems. And I'm opening today what is actually the launch of a very much a joint product, a joint effort on behalf of the Observatory and the European and the OECD Health Division. But this launch is actually organized by the OECD, but very sadly, Federico Gunais couldn't join us. So I am deputizing for him, which is a great honor. We're here because the handbook is something that we think is a practical and useful tool. We're all very conscious, I think, of the pressures on health systems, the need for preparedness. We are also very conscious that it's countries themselves who need to be able to look to stress test to understand where they are coming from. And this handbook should help them to diagnose problems, to design remedial action, and then to work through what they could do and the implications. Because if you take remedial action without thinking about that whole kind of global HSPA framework, how do things connect with finance? What are the workforce implications? What are the governance dimensions? Then anything that you plan won't work as you expected. So we're very, very fortunate to have been able to work on this under the leadership of DG SANTE and Maya Matthews, and of course with Bella Dijker as well, in something which was very much a joint enterprise. And we're very proud and happy that we can have such a distinguished panel to launch it. And if we could, I'll go first to you, Sandra, leader of DG Research. God, please someone shoot me, DG SANTE. I'm so ashamed, so ashamed. Over to you.
Thank you. I would like to somehow say that in general, I don't go to many meetings. People know it, even from this side of the trenches, that I'm very select because I don't like to go and waffle. But today I would not have wanted to miss this meeting because there are many friends. Some of them perhaps, you know, with their Swans song, and some of them, you know, and some of them really devoted friends for what DG SANTE is trying to do, bring, I would say, systems, health systems, to a level which is sustainable, because, you know, the difficult part is the money, So I would like to, of course, thank Francesca, Giuseppe. I would like to thank Dirk, because, you know, he's here not just in his capacity as presidency, but as a man who has seen, I would say, firsthand the disaster of COVID, and he knows much more than I can ever learn, because, you know, he saw it also from the national part. And then I have my dearest friend Hans here sitting next to me. Always, I would say, a person that I like to be next to, because it's always good to have WHO Europe next to us. I would like to thank, of course, you mentioned Maya and Bella, but I perhaps would like to thank somebody who is hiding in the public. It's Professor Jan de Massener, because we have been, please a round of applause for him, because he has been the inspiration. And the real thought behind this is that, you know, when in 2020 we were in the tumble dryer of the COVID, what we thought is that in reality, it's the last or first mile, depending on how you see things, that really counts, is the primary care. If you look at the countries that fared best, it will not be the ones that had huge hospitals, that had huge things, you know, in terms of, I would say, super health systems, private ones or whatever, but it's the ones where you had a doctor next to you. And many, may I say to you, many, especially in my dearest country, Italy, lived out of the advice of their own pharmacists. So, you know, we were desperate. We did not understand what was happening. There was a lot of imagination by the doctors also on how to treat these people. This is why, if you bring yourselves back to 2020, we had different waves of desperation. The first wave was the masks. Still remember everybody going around thinking, why do we get the masks? Then, there was ventilators because the people unfortunately had to be brought to this coma and are in ventilators. That was very bad. And then, we had this thing of vaccines and therapeutics. Therapeutics was also something that struck me. I don't want to make any names in terms of publicity, but there was this complete search for remdesivir at a certain point. I remember we had to do a procurement for that because everybody wanted to have that medicine as if that was going to solve the problem. The reality was that even today we have long COVID. COVID is staying here, it's not going away. And therefore, I think that people should be reminded that the vaccines not only saved lives, but long-term are the hope to put a brake on something that remains not very clear. You may imagine that everything has been discovered by now on COVID, but you would be wrong. So the point of me being here today is that the book, which I still have in my printouts, is something precious. Is something precious because it took a long time and a lot of work. So again, many thanks to both the Observatory and OECD that they joined in this adventure. Not an easy handbook, but a very useful one. So perhaps it's an exhortation to member states. Member states should try and not just use the book, but use it as a recipe book, meaning that you would need to perhaps stress test yourself. Perhaps, this is not something that should come out from somebody from the Commission. It's not the Commission that will stress test you, but you yourselves could be asking somehow, perhaps, OECD, or I would say the Observatory, to help you implement this recipe, because it's only then that you may have better arguments for your finance minister. Because I go back to my first point, the sustainability of the systems, it's also a bit of a converging point between different trends. So we are becoming older. There are these chronic diseases that are becoming much more expensive. Medicine has evolved, so we no longer treat people with, I would say, a pill, but it's a much more complicated system. With the biologicals we're having, or biosimilars, we're having better results, but they are not, they're still expensive. So you have more diagnosis, more personalization, more machines at the start. So people not coming to the hospitals, the system is undergoing a revolution. In my small world, I think I have seen this in other parts, and it's the tertiarization of the thing. This is becoming more of a service. It's not the drug that you take, but it's the service. So how do you make that resilient in your country? Well, this book can give you some clues, can be extremely useful, but you need to use it. My people are horrified because I never use the good briefings here. So I would like to go to a place where I would not, and it's the reason why I am here today. So let me say what I also saw with COVID, and it's very important that you realize where I come from, is the inequalities and the inequities that exist, but they become even more strident. This is something that you need to put into the equation of your health systems. How do you grant access to all countries that are poor, countries that are rich, access to all citizens? This is a political choice. So you may realize that good, high quality health only comes when it is very diffuse, very dispersed, and very much broad in access. It's not, with small centers of excellence, important as they are, and they can be locomotives, but you need to have a good public health system. For us in DG SANTE, we're very much in that. We think that the partnership with the private is vital. This is also the reason why, when we were discussing in the EHDS trilogue, we made it possible for research, wherever it happens, to have access to the secondary use of data, provided, the national authorities certainly vet the entity that is asking for access. But, let me say, it's important that you understand that the broader the research, the broader, I would say, the numbers, the higher the possibility to find the treatment. So in my view, this book is complementary really to what we are doing in DG SANTE at the moment with the implementation of the cross-border health threats regulation. And I know that my colleagues, both Francesca and Josep, are very much into the know of the difficulties that we have there. There are difficulties in terms of the fact that ECDC will need to visit the different member states to create a preparedness plan. And as I say, the first link is the primary care. So it's very far away from the countermeasures that you may think. It's not necessarily the stockpiling that will be vetted, but what will be vetted is really what are the structures, the beds, the hospitals, how fast can they ramp up if there is a need for more space. So it remains for me to thank the OECD, and I think the OECD is a sort of sparring partner, if not, I would say, an accomplice in many of my adventures, because I like numbers. I would like to thank the observatory, and I can only say it's second, not because it's second, but because the observatory really has been the inspiration in many adventures where we need more daring do. So with Josep and with his leadership, we went for very it's not necessarily the case for the handbook, but we went into very difficult areas where angels fear to tread, because they have the expertise, they have also the independence. So I would like to thank both these institutions and with the same degree of, I would say, gratitude, because they have made a dream of 2020 true, and it vindicates also the existence of experts in Europe, good brains in Europe that give us, I would say, input. I would also like to thank the 3 countries that were the guinea pigs, so Finland, Greece, and Spain. Spain is Asturias, specifically, one of the regions. They were the guinea pigs, and Bella was just telling me that the stress test for Spain was really heat waves. And we can only surmise how useful that will be for the future, not just in Spain. These are pilot workshops that we had, and the countries seem to be extremely grateful for the pilot workshops, and we have learned a lot, of course, otherwise it would not be possible. So again, a word of thanks to the expert panel on effective ways of investing in health, which was the one that, really imagined this thing in 2020. Let me say that I would also like to thank this group, because it was helping me in many adventures that today many of you are somehow benefiting from, like the Climate Observatory, Health and Climate Observatory. I know that my good friend Kurt is a devoted, I would say, client of that observatory. But when I first started positing that the existence of that, with a bit of input from the experts, but also from Josep, that saw the thing coming in 2020, and I put the money in 21, everybody was thinking we were mad. Today, everybody says, oh, now that observatory has found many fathers. At the time, there was only one stepmother, and not even thought of. So it's just to say to you, you need to cling on, really believe in what you do. Personally, I'm tenacious. So, if I find that there is a good idea, I persevere, unfortunately for some others. So this is really a big thank you to that expert panel, because they had this first concept and we followed it. I could not also finish without thanking the expert group on health systems performance assessment, because they had a report on measuring resilience. That it's quite difficult to measure things, but measuring resilience, you can imagine it's quite a complex domain, and they are the ones who really somehow cooked the methodology. The methodology was something not easy to arrive at. So, as I said, member states, you're all welcome to use it. So policymakers, but also policy sufferers are all invited to use the handbook. And as I say, I'm very proud to be next to the Belgian presidency because, you know, they are very committed. It's a presidency with whom we are working fantastically as DG SANTE, very committed in many domains, where, as I say, we felt quite lonely, and I would say from shortages to preparedness to, I would say, even other topics like workforce, you know, that is also another difficult topic for Europe. Huh? So for the next adventures, I give you some sort of slot, rendezvous in the future, but there may be many accomplices in murder that are sitting here for the next adventures. Thank you for your patience, and sorry for being a bit long, but I wanted really to do this personalized, like medicine of the future. Thank you.
Sandra, thank you very much. I think you've touched on so many of the things that matter to everybody here, to that sense that whole systems connect, that it's about equity, and that also that countries have to lead the way, yes, and that this is just the Commission and the Observatory and OECD enabling. Yes. And if I can now, please, Francesca, there were so many things that Sandra said that I know you can pick up on how you measure, on how you test, on the lessons of other sectors. Over to you.
Thank you very much, and obviously difficult to follow Sandra, but I think first of all, I mean, the people who are here are probably a testimony of the importance of this issue. I mean, it's quite clear that we have not done well enough during the pandemic and that we need better tools at our disposals to do a better job for the future. And I think that's the first message that I would like to give. I mean, what we have done through the elaboration of this handbook and the partnership in crime that we had with the support of the Commission and with the Observatory with Joseph is really trying to go in that directions, the directions of having better tools that will allow us to do a better job into the future. Now, I have three main points I would like to make. The first is precisely linked to that. I mean, when we talk about tools, what do we mean by having better tools? We need, of course, to have better data, more granular indicators, data which are available more in a timely way, because that's what happened during the pandemic, that we didn't have enough data that would support decision-making in a timely matter. We need to have also, and to keep decision-making with the tools to make sense of this data, whether there are visualizations or even statistical modeling, these sorts of things. But then thirdly, and importantly, we need also to have people sitting at the table to make sense of those tools and those data to inform decisions. And decisions can be very complex because there can be complex trade-off that needs to be made. And those cannot just be resolved by a tool in itself. You really need to sit around to discuss at country level, across countries as well, how to respond in the best way. And that's my first message, you know, that this test of health system and this handbook that we have made, it's made to provide this better tool for addressing complex crises into the future. The second point I would like to make is that crises do not happen in isolations. And actually, we have seen through COVID-19 how the health system is so incredibly interconnected with other sectors of the economies. And managing that interconnectedness in crisis and across different sectors is what actually is particularly challenging and difficult, and we need to do better for the future. So if we look obviously what happened in the health sector, it's quite clear that there were difficult trade-offs to make between health and economy. Closing down the entire economy, you know, obviously has implications for the functioning of economic activities, for the livelihoods of individuals. Of course, it slows down the circulation of the virus, but there are difficult choices and trade-offs that needs to be made. And even looking at health versus the education sector, decisions to close down and do a lockdown has implications for the participation of pupils into their regular activities and can have implications for the long-term building of human capital. And what we have found during the pandemic is that we didn't have those tools again, and so we have not had the people sitting around the table to say, how do we manage this complex trade-off in a situations of crisis. And that's what we're trying to do really with this handbook. But there is also not just the effect of a health crisis on the broader sectors in economy. There is also the fact that crisis may come from outside the health sector and have a significant impact on it. I mean, we have seen it in the past, in the context of the 2008 financial crisis, that had a huge impact on the health sector. There were decisions about austerity, about cutting budgets. At best in some countries there was an increase in health spending in real time equivalent to the increase in the economy. But clearly there are trade-offs between prudent fiscal management on the one hand and the implications this has on health system, particularly for vulnerable populations. And Sandra, you mentioned the issues of equity as an important one. But if you look also at another disaster that happened in a different sector, the Fukushima nuclear accident in 2011, again, policymakers had very difficult trade-off to manage, for example, in terms of displacing of individuals. Many people were elderly people living in areas which were close to the accident, huge risk of radiation, but also risk to their mental health by moving them, and also in terms of the continuity of elderly and care that they would receive by moving them. So again, we need to have tools that allow to manage those complex trade-off. And the third point which I want to make is that we can learn actually from other sectors, and we should, in the health sector, look a little bit more at what other sectors have done. There is a very rich experience that we can see. There are methodologies for risk testing and stress testing sectors, which have been then regularly applied into exercises in outside of the health sector. For example, following the 2008 financial crisis, in many countries there have been a mandated stress testing exercises which regulators have asked to the financial institutions. So regulators would divide some baseline into some shock scenarios and then ask all the different actors to use key indicators to see what will happen to their particular institutions in situation of stress. And that's one example. Again, the other example in the nuclear sector, there are regular stress testing exercises which are done with the idea of ensuring the continuous safety of operations. So I think we need probably to look a little bit more, and there is no reason in a health, in a sector which is so critical like the health sector, not really to think of applying these stress testing methodologies and tools, which are so fundamental to the functioning of other sectors of the economy. So, that I think we need to look a little bit beyond what happens in health. And I'll stop there really with thanking again, all the expert groups, the countries that participated, the people that worked on this manual, and those who are here that have supported this work. Again, I think the message is we can and we must do better, and we need to look a little bit outside our usual comfort zone.
Francesca, thank you. I think that notion of using the data and the research, but in a practical way for testing, and I think in this context and for us, maybe mandatory is a step too far, but that country-led idea, I think so important. And Giuseppe, I was wondering if you could talk about a little bit about what's special in health systems, but more the characteristics of resilient health systems. And if there are health systems that are performing well, can they relax and assume that they are actually resilient?
I like that one. Thank you. Actually, let me start with something else. I never answer a question. Sandra, fathers and mothers.
Yes.
Fathers and mothers. I love to be the father or grandfather of this one, but I'm not, for once. I think we need to thank you, as the leadership, but I like to say Maya Matthews is behind the country-based expert panels, of course, and experts, but who put that idea on the table, who pushed us, bullied us, supported us to do that work. So we are very grateful because you had a vision, Maya, and Sandra, we have to confess something. I hope Francesca doesn't mind, but we're in family here today. When in 2017, your staff said to us, you have to include the dimension of resilience together with effectiveness and access. both the OECD and the Observatory were very resilient to have resilience as a dimension, because we said, this cannot be operationalized, it's impossible. There you are. It's been operationalized. So in 17, well before the crisis, you guys started with this idea, with this leadership. Actually, I must say the Observatory at that time had done a policy brief, but we didn't see clearly how that could put in place. So for me, seeing that is such a pleasure. And you know why it's such a pleasure? Because resilience is one of these fads and trends and fuzzy concepts. These days, people say equity, efficiency, and resilience. You know, nice and beautiful, and resilience. And the key is that now you pushed us, Maya, to make that operational, clear, indicators, measurable, quantitative. Yes, Francesca, absolutely. The data, the impact. And that's what's really exciting about this project, that we managed to go from the fuzzy to indicators that are clear, that I wouldn't say name and shame, but benchmark, help countries to compare with each other and see. I love what you said, Sandra, and go to the Minister of Finance and say, hey, if you don't give us money for that, next shock, we are down the drain. And we are down the drain, you become insecure, you become unstable. So it's really powerful tool, and it's such a privilege. We almost done it, we would have done it without money. I can tell you that now afterwards. Although we need more money to continue, because it's such an exciting thing. I know it's too late to say it now, but anyway. No, sorry, and now I'm going to respond. Susie, don't look at me like that, please. Three sets of reflections, and within the 7 minutes, I only spent 2, I think. Only 2. So the first is, what are the features of that? The beautiful thing about that, of course, I'll start talking about the volume we did with the WHO and the Commission at the very beginning, trying to learn the lessons. And then the very good exercise of the OECD, WHO headquarters, Commission, and so on. There was a clear convergence about these factors. And the presidency now with this Euro Health that we're publishing now, again, highlights and echoes these factors. We all know them, but let me just spend 30 seconds in mentioning them, even if they become like a mantra, but they are real. Across sectors, it's the first time, probably, that health in all policies is made clear. Every single shock and resilience has to be with other sectors. So Hans, while we've been pushing for years at WHO to do that, the resilience has the biggest reminder ever about health in all policies and health for all policies. Without other sectors, we don't have a chance. And of course, intergovernment, but that's going to be my second point. Political leadership is so easy. It's one of these unfashioned words. Leadership in evidence-based decision-making, engaging civil society, engaging and communicating, creating trust and transparency. Hans, trust, transparency, and transformation, very much what it was your conference, our conference, the Observatory participated as well in Tallinn. Health coverage, but it's not only health coverage, it's the ability to be flexible and target the vulnerable groups. Remember the financial crisis, we did all these studies saying, well, the financial crisis didn't have an impact on mortality in over terms, or very slight. There were paper after paper after paper, 3 after 3, cut to demonstrate and to talk about well, it was an impact. But when you look at segments of the population, it's always the same. The vulnerable populations that get affected by every single crisis, be migration, financial, COVID. And this is where the ability of a system to reallocate resources to the Belgians did many things well, and one of the things as well was targeting those groups and looking out of pockets and so on to get those groups access to the system. Health workforce, well-trained, we heard about that, it's the big crisis. Capacity of frontline services, transforming, which leads me to the second point. So first point, this handbook is using the WHO Observatory framework to look at key indicators of resilience. Second point, responding to you, Susie, there you are. They look at performance and transformation. So what we're saying is, you can have a system with very good high performance, and during a shock, goes down the drain, because it's unable to be adaptable, flexible, transform. No system, I'm sorry, Sandra, we all both agree, I know, will be ever prepared with shocks. We can, you say that?
I say all the time that being prepared to the crisis is a bit of a delusion because it would be extremely expensive. Imagine that you always keep it so high. You know, it's in a crisis, you need to be reacting fast, but to keep that level of preparedness throughout is impossible.
That's exactly it. And then again, I'm sorry, we need to put this baby on the table. You'll see that a lot of the indicators are not only on performance, but on ability to transform. The governance of funding to reallocate quickly, the governance of access, the governance of delivery that can introduce payment systems and digital very quickly, the governance of legislation and regulation and information systems that adapt to change. That's the key element. Again, we're going to transformation, Hans, and we're going to trust. Trust has been the key element. Trust in policymakers, by civil society, health workforce, patients, has been a key element of resilience during any single crisis. And that's very much what this handbook is trying to tell you, indicators of performance and transformation. So yes, Susie, it's necessary to have performance, but not enough. We need to have as well ability to transform and to change. And finally, quickly, intergovernment action. We've been saying that for a long time. It's not only viruses that cross borders. Every single shock has been analyzed here, and you can think of your minds, have a cross-border European Union, WHO, Europe, and worldwide, each one of them. And lately, I'm saying that one of the big shocks is the commercial determinants of health that account for 30% of the mortality that could be avoidable. An area very much you're pushing, Hans, and the Commission is pushing as well. Shouldn't that be an element of resilience that we need to tackle together? Sandra, it's politically incorrect, and there being a member state, but is subsidiarity applying to many shocks across borders? You cannot say anything, I know. But on resilience? Seriously. And this line up here, particularly with the Commission and WHO and a member state that's leading the presidency, tells exactly that. We need to work, keeps coming down. We need to work across these organizations in these countries to put these systems in place. And Belgium now, pay attention, it has the presidency, well, you'll say it in a minute, but can I say it as well? Your presidency is talking precisely about the EU role, and by extension to the WHO role, in supporting member states. Okay, I'll stop. I like to be like Saint John the Baptist when Jesus, announcing Jesus, okay? Okay, I'll stop here because I'm getting out of line here. I'm unhinged, as they would say about an American president, ex-president. So just let me say that this book is actually about this. It's about giving member states the opportunity to self-stress test. And here, the organizations, here, the OECD and the Observatory will be ready, hopefully with some funds, and if not, we'll be ready also to support these member states to self-test. So thank you, Sandra, because it's been, I'm not emotional now, but it's been really, really a major opportunity to do that. It's been a dream. So thank you very much.
Thank you, Giuseppe. For just one moment, I wondered if the ceiling would open and a thunderbolt would, take you out. I'm glad it didn't happen. I think all of the things you were touching on, that you have a perspective on, and I think particularly about leadership, the role of the EU, and actually the role of WHO in building resilience. Can I introduce you to Dirk Ramakers, who is speaking as the president of the Ministry of Health in Belgium, but also as a really key player in the Belgian presidency. And I know you will tell us a little bit about how your agenda picks up on all the things we've been talking about: preparedness, resilience, governance, leadership. Thank you.
Yeah, thank you. I just realized how lucky we are that we still have freedom of speech in this country and then also in the EU.
Yes. Very well said. Very well said.
So your question was, how does resilience echo on Belgium's concern as a president of the Council of the EU? Well, things have changed. I think that the EU for a long time was thought to have very little to contribute to health and also health policy. That era is behind us, clearly, as also expressed by Sandra quite well, I think. The scale of the EU's impact on health is clear, is enlarging. And so the question how to best use it, not just for the health of individual citizens, but also to build resilient, healthy, not healthcare systems, but societies, I think that's really keen for the next years. And that's also, I think, the basis of the Belgian European Council presidency. A lot of conferences, and some of you are invited or are participating, so thank you for that. Josep already referred to the Euro Health publication. I can recommend it to you. There's an article that analyzes all the recommendations of large international reviews from the COVID pandemic. And maybe we should, starting from now on, stop talking about COVID. Let's talk about the future and other health crises. So I can really recommend you to read that. So a lot of recommendations we should put into practice. Real world action. Stop just discussing and talking about things like resilience, which is quite nice as you see this morning. And I think that what we're talking about here, this tool, this test instrument, is for me quite important. You can't talk about resilient systems without having tests. Only a few months ago, we had OECD evaluating our COVID response, positive points, negative points, of course. In May, Belgium will be visited by ECDC to see where do we stand at the level of pandemic preparedness. So there also we will be able to learn a lot of things, undoubtedly. And I just promised to Josep that this will be for 2025.
Wow, thank you.
Still have to look for the funding, but okay. Yeah. So maybe a few points to focus on. I think already a little bit mentioned, but I think that all the reviews, all the experience that we do have highlights the role of effective political leadership. That means indeed legislative frameworks, planning, coordinating, and so on, but also effectively coordinating between different government sectors. That applies for member states, but also for the European level. Preparedness and health system resilience should be tested on a very regular basis. So let's hope that this is really a starting point. I think that also this is a common initiative, and DG SANTE really was leading this initiative together with the Observatory and the OECD. And so in my opinion, message to take home, put this at your bed table and keep reading it and keep applying it in your own healthcare policies. I think that COVID-19, and so I'm mentioning it for the last time now, Susie, was just a first small test. I think that health threats will appear to multiply. It's clear that we are facing quite nearby wars. The geopolitical situation is clearly changing. And also, of course, we already referred to climate change, and Hans will maybe also refer to that, because WHO is quite focusing on the relation between health and environment. And this will be increasingly important, and I think this will take other measures than that we saw during the COVID crisis, which were short-term temporary measures. And so we have a growing threat, terrorism, organized crime. Next to climate change, are we prepared for CBRN attacks? I don't have to give the answer, I think. Also, Europe is taking several initiatives, which is a very good thing. It will threaten not only our public health, but also food systems, security of our nation, and in general, the political stability we were quite fortunate to have the last decades. So I think that what we're discussing today will be very important, will be crucial for the next years, for the next decades probably. Adaptation towards climate changes, adaptation toward geopolitical situations, and of course, as already mentioned, with all this in mind, this will cost money. And we can hope that we can all convince our finance minister or prime minister, but as you do know, we are also facing other economical challenges, especially Belgium also is, because as you didn't mention, we indeed had a lot of measures to support our economics, but it also costs a lot of money. So I think for the next years, increasingly, we should also look within our current systems, because I think the financing probably should come also from within our health and healthcare systems. And so more than ever, we have to cut back on excessive, inappropriate health services. As already mentioned, how many hospitals do we need? What about the importance of primary care, which in general is also much more cost effective? And we're already talking for that also a long time, but let's put that into practice. So reduce waste and reduce also ineffective use of resources, I think will be quite crucial, quite important if you want to increase the resilience of our systems. That focus on low-value healthcare was also mentioned by the HPA expert group recently as a priority. So I think there also we should continue to work upon. So final word, thank you. All of those involved in this instrument. And I think for me, or especially, we will mention it in all the future conferences in the next couple of months, that this is quite important. And let's hope that indeed we are able to convince the majority of European countries to use this, and especially also to collaborate and to interchange their mutual experience with this instrument. Thank you.
Dirk, thank you very much. At that sense that it's both member states and the international bodies that coordinate and care about them have to come together and actually take action, real world action, I think is really important. And I think, Hans, if I can come to you now, Hans Kluger is the regional director of the WHO European region. I've got that wrong as well, here it's better. And I think, you know, a leader of a huge and diverse group of countries, and I think also very, very aware of the things that Josette was saying, which is health system is so much a part, and health is so much a part of all of the wider activities. And I'd like to give you a few moments, please, to reflect. Thanks.
Thank you so much, Susie. And if people wonder why I'm sitting here, these are one of the things that I'm missing a lot. You know, often journalists ask, and what do you miss as region director? Is to be part of this gang, I must say, because as a health system director, working very closely with you, Francesca, was always a very straightforward relationship, also with Mark, do him best regards, with Josep and Susie, right, who introduced me to the health system group. It's wonderful to work with you, Sandra, one of the few high-level EC officials that you do not always have to be politically correct. And then, of course, with Professor Ramakers, I really start to appreciate so much, first and foremost, during the COVID-19. I mean, for really getting Belgium back on track, we should not be forgotten. So we say in WHO always that health may not be everything, but without health, there is nothing. I mean, if a person is healthy, including all of us, then you want so much. But if you're sick, and everyone who has had this period in life, there is only one thing that you really wish, and it is to be healthy, because the rest, there is really nothing. And I think this is a very important phrase when we're talking about heads of governments, heads of state, because the key issue now is to keep health and health investment at the top of the political agenda and the next European Commission. And I think that Belgium cannot be commended enough for doing exactly that, really, to work through the presidency, not only on health, but with the Minister of Development and Foreign Affairs, to put universal health coverage at the top of the agenda. I think the experience of the last years made us tragically clear that we can predict who will die first when the next crisis comes along. First of all will be the people with the lowest health reserves. It means the youngest and the eldest, including in the elderly homes, where we left many people behind. Second is the people with the least access to resources and power in society. And the third one, very important to remember, are the people with chronic diseases. Even at the height of the COVID-19, people with chronic diseases were dying 3 to 4 times more than the people with the COVID-19, or it were the, like in the hospitals in Italy, the people with the most extensive clinical manifestations. Which brings us to the core mission of WHO, it's to leave no one behind, because it are always the vulnerable who are hit first. We saw it yesterday at the European Humanitarian Forum, organized by the European Commission. Thank you, Sandra, for this. Right, whether it is, I was at a panel with Ukraine, with Deputy Minister of Health. We saw it in the earthquake on Turkey and Northwest Syria, in Gaza, Israel. It are those with pre-existing vulnerabilities who are hit double. 10 January, we had a great expert meeting hosted by Professor Ramakers in Brussels. Thank you, Dirk, actually co-facilitated by Observatory through Professor Mark McKee, with experts from the representation of 53 member states, and a number of issues became clear. Number one, and you mentioned already, Dirk, was on national health security. Because now it's true, if you talk to a prime minister or president, they don't want to hear COVID-19, almost not about health. They told you guys got a lot of money, no, let's move on. But national health security is a very powerful argument, including indeed the CBRN and the collaboration with defense also and with NATO. Second is on the mental health. This is the current pandemic. It's very, very worrying in conflict zones, but also in non-conflict zones. And then you mentioned already the climate change. From here, I will go to Mons, where I believe Prime Minister of Belgium will open the biggest conference of the regions, the Committee of the Regions, with President of Wallonia, Elio Di Rupo. And it is about preparedness and climate change, the climate resilience, where early warning systems are very important. Heat health action plans, where we're working very closely with DG Clima. For example, 62,000 people we lost in 2022 due to the heat waves, and 2023 was even breaking more records, and ultimately to get the people at our side. So I want to commend again the Belgian presidency really for calling for a Europe that cares, prepares and protects, and is going to put, among others, one key issue forward at the high-level conference next week, 26-27 March, is the issue of the health workforce, where I'm very honored to be present. You mentioned it actually, Sandra, because this is actually, we believe, the biggest crisis of all in the health system, and there's no health without health workforce. And it's a congruence of many crises. It's a crisis of labor, because of our demography, decreasing infertility and increasing aging. Then it's the education, it's a mental health. In some of our workforce, we have up to 60% of burnout. It's a gender equality crisis, because the majority of our workforce are women, but they have a 24% of salary gap and proportionally much less positions in the leadership. Education, right? We have to look at the curricula. I know, Professor de Masseneer, dear Jan, you always looked at that one, whether our curricula in the educational institutions are fit for purpose, including on digital health or on multi-morbidity, and of course, a financial investment crisis as well. So to be resilient, you know, it's terribly important that we nurture really our health workforce. For me, resilience means to bounce back stronger after a crisis. It's not going back to the pre-crisis state. It's actually to come out and bounce back stronger. For this, and Josep, you alluded to, we need to be good listeners to the frontline workers and to our patients to co-create the solutions. They are facing the problems, but they have a lot of the solutions, really. And that was indeed the theme of Tallinn. Finally, the one message that I would like to convey in my position as WHO Region Director of 53 member states is that no one is safe until everyone is safe. So I appeal to your solidarity with the Western Balkan, with Central Asia, Ukraine, Moldova, Georgia is great. For example, I was telling yesterday, Sandra, that Ukraine can benefit from EU for Health, for example. I think is very, very important. And ultimately, with our brothers and sisters of the African region, tomorrow, many of us will participate at the EU-African Union Summit under the EU presidency. Congratulations again, Dirk. Yeah. I think very important that they do not have the bad feeling that if there's not a crisis with, and they struck with vaccines and with medicines, that there is a genuine partnership between North and South. Without health, no growth, no stability. And I would like to congratulate you, Susie, Francesca, Sandra, Josep, Maya, Dirk, you for great leadership for putting this work together. It was very, very necessary to have such a one, and we will be very happy to advocate to member states and assist also member states, right, to accompany them into this stress testing. Bravo, bravo. Really, bravo. Bravo.
And thank you so much. I think that notion of the workforce as an example of how everything is connected and how you need to look across, and the idea of you being able to help member states to test resilience would be a fantastic thing. Can I add just a few thank yous to your thank yous before I ask you to descend? I've been thanked a lot, which is lovely, as has Giuseppe, but I have to say the work was led here by John Silas, by Phil Hayward, by Marina Karanicolas, and magnificently, and we had huge contribution from Julia Zimmerman, from Naomi Levy, from Ines, Ines, I won't get your surname right, I'm so sorry, but say it. No, that's not all of it. It's way longer on your email. It's like 28 syllables. Okay, 2 surnames. Okay, the short one I should have known. This team has been have worked unbelievably hard. The member states who I know, Sandra, you thanked for us. This has been a really collaborative kind of thing. John, behave. And it's been a really nice thing to see the observatory and the OECD working so well together. And Phil, although you left before the end and Naomi left before the end as well, it's really lovely to see you back here to launch it. Dear panelists, I can thank you very, very much for your contribution. I know that some of you may need to move on to another meeting. If you would, anyone who is able to stay is very welcome to sit in the front row, and then I will ask Phil and Julia to come up and explain the handbook. And one last thing, and I apologize for my timekeeping. What could I do? I'm afraid we have no time.
Jumping out.
So sorry. There will be other sessions with questions, honestly.
Great job. We'll be very worried if we do it.
If I can ask Phil and Julia, I will hand over my microphone to no one.
I've got Phil. Good morning, ladies and gentlemen, dear panelists, esteemed guests. My name is Julia Zimmerman, and together with my colleague Philip Hayward, it is my pleasure to take you through Strengthening Health Systems, a practical handbook for resilience testing today. In my brief presentation, I will first give you a broad overview of what resilience testing is. Then I'll take you through a couple of the core concepts that underpin resilience testing and showcase some of the material we make available. At its core, this publication is a step-by-step guide on how to conduct a health systems resilience test. A health systems resilience test is a tool for policy making. It helps assess a health system's strengths and weaknesses when faced with a shock, and helps pinpoint the kinds of action that will make a health system more resilient going forward. If I had to describe a health systems resilience test in one sentence, I would say that it is a carefully prepared, highly structured workshop. First, there's a period of preparation where the parameters for the resilience test are decided, where existing data is reviewed, and where the resilience test day is prepared. The resilience test day is a day of structured discussion where relevant experts and stakeholders come together to discuss and assess health systems resilience. Resilience testing has several advantages. Most importantly, it is able to detect critical health system weaknesses. It can identify targeted, practical options for remedial action to improve health systems resilience in future. The approach generates insight and evidence, and it is collaborative and fosters stakeholder participation. It is also a systematic approach, which means that this approach can be used in many different contexts. So it is not only possible to conduct a resilience test at any national level, but also at any regional or local level. Now you have a broad overview. I will take you through a couple of the core concepts that underpin resilience testing. First, the definition of resilience. We use the definition of resilience developed by the Health Systems Performance Assessment EU expert group on the report on health systems resilience in Europe. Like many other definitions of health systems resilience, this shares a couple of core key ideas. The first idea is that resilience always needs to be seen relative to a shock. The second is the idea of time. So we're not only interested in what happens during the shock, but we're also interested in what happens before the shock and after the shock. And the third idea is that of adaptation and transformation throughout the system. The second core idea I'd like to introduce you to is the definition of the health system we are using. As you can see on the slide, we're using a very broad definition of the health system. However, sometimes societal functions that sit well outside the health system have a huge impact on health systems resilience. The resilience testing methodology is flexible to accommodate for this. Functions sitting outside the health system can be considered during resilience testing. The most important point being that the focus remains on the health system and the implications for health systems resilience. Resilience testing is also underpinned by these two frameworks. The frameworks ensure a systematic approach, that nothing is missed, and that the right questions are asked during the resilience test day. The shock cycle introduces the concept of time and ensures we consider what happens pre-shock, during the shock, and after the shock. The HSPA framework introduces a health system performance lens and ensures that no area of the health system is missed during the resilience test. Resilience testing uses a dedicated hypothetical shock scenario to assess the resilience of the health system. Many different kinds of shock scenario can be used for this. The most important underlying factor is that the shock scenario has to really push the health system to breaking point. Only then are the strengths and the weaknesses of the health system really highlighted. In the handbook we're launching today, we make available 4 different example shock scenarios. You can find these right at the back of the handbook in part 3. We have a pandemic example, a heat wave scenario, an AMR shock, and a financial crisis. These are generic examples that are easy to pick up and adapt to any national context to run a resilience test. This takes us to the front of the handbook, which is the step-by-step guide. This breaks down resilience testing into 5 easy steps. It is aimed at a small organizing team that takes care of the whole process and facilitates the resilience test day. The first 3 steps are the preparatory steps that include the desk work, to do the research and analysis, to decide which shock scenario is used, and to develop the scenario. Step 4 is the resilience test day, where stakeholders come together to assess the resilience of the health system given the shock scenario. And step 5 is a period of follow-up, where the evidence is collected and remedial action initiated. In addition to the handbook, we have also developed a website to assist test organizers. This is a collection of past resilience tests that are made available for future resilience test organizers. One of the things we have learnt going through this project that it is extremely valuable to have many examples of past resilience tests when putting together a new resilience test. Therefore, we have made this available for the future. That concludes my brief presentation. You now have an overview of the methodology, an overview of the handbook, and the materials we make available. Over to Phil.
Thank you, everyone. I'm all that stands between you and coffee, so I'm going to be adaptable and make this presentation a little shorter than it was originally intended to be. So if there's any of the points that people would want to pick up a little later, go ahead and do them in the later sessions. Basically, I'd like to outline why we've taken this approach to testing health system resilience and what we think are the 3 key ingredients to successful testing. Simply put, and you heard this over and over again by the panel, the process of assessing and improving resilience is hard. And it's harder to action when you're not actually in a crisis. And this is one of the big issues. Resilience is front of mind when you're in a shock, such as the, we will never mention it again, COVID-19 pandemic. But it's more difficult to assess the strengths and identify the potential vulnerabilities of a health system when it's not experiencing a shock. Then your focus is on business as usual and not what will happen when your health system's under stress. You often don't have the information to assess resilience. And this is our starting point. And there are 2 major drivers for the approach that we've taken in the handbook. First, the handbook is about facilitating health system change and reform before it becomes necessary and urgent. Assessment needs to be linked to action. The purpose of the handbook is to increase the confidence in the assessment to identify key areas for reform, make the case, and part of the financial case. Second, the handbook aims to ensure decision-making is formed by a full picture. In other words, the context matters. And we heard this over and over again from the panel, that there's plenty of evidence to suggest that regularly measured quantitative indicators, such as the number of healthcare workers a system has or its financial resources, are important for resilience. But they're really only half the story. They don't offer the full picture. The resources available matter, but decisions about how those resources are used also matters. These decisions might be in turn influenced by the way the health system's organised, how it's governed, the level of trust participants have in the system, and so on. And the handbook really intends to draw out both of these issues: the impact of stress and the underlying values, interests, and dynamics that are the context in which decisions will be made, and ultimately what determines health system resilience. Now, there are many important steps to be undertaken in a successful resilience test, and Julia's outlined, and the next panel will elaborate on them. But let me highlight what we think are the 3 key ingredients for a successful assessment. First, and this sounds obvious, but you'd be surprised about it, you actually need something to discuss, something that motivates the discussion, the ownership, and the action. And that's the reason we're suggesting using a shock scenario, a concrete threat to the health system that participants can identify and think about in their own context. Secondly, testing requires independent facilitation and contextual expertise. Facilitators need to have knowledge and predict whether challenges may arise during a shock, and to be sufficiently independent to be able to probe the consequences of a shock across the entire health system. And finally, you need a diversity of participants. With this, you have a better opportunity to understand how the system works as a whole, its holistic effect when it's under stress. Without diversity amongst the testing participants, you can miss some of the cascading effects or the unanticipated consequences to a health system that may flow. And basically, there are many decisions that we need to do to undertake a successful stress test. In the handbook, we share our experience of this, what we found works. But we're not prescriptive, recognising that member states may have different systems with different pressures and different dynamics. But we would recommend keeping these three ingredients in mind alongside the HSPA framework and the shock cycle. Now, I will briefly turn to each of these and I will go through them very, very quickly. So basically with the shock scenario, it needs to be a scenario of concern with consequences that are made clear to all participants. And we suggest that the scenario be decided with the health ministry or the agency. So the test is seen as practically valuable and there's generation of ownership of its results. Now, this is a really important point. It's not simply about running through a plan or a simulation that you've prepared in beforehand. And it should not be able to be simply solved. These are meant to be tricky problems. It has to be large enough to generate challenges and have a cascading effect through beyond the immediate shock and through the health system. It will also determine what questions will be asked and what strengths and weaknesses will be identified. It is the interaction between the scenario and the system as we represent it with the framework that informs us. And so testing can and should identify strengths of a system. However, what we're really using it for is to identify vulnerabilities for the reform. And as you can understand and appreciate, that it requires skill and judgment to facilitate the testing of the shock scenario. In the next session, you'll hear from panelists who've actually performed this and what they've found works and doesn't work. But as I said, they need to be sufficiently independent to be able to challenge the system and ask probing questions. But they need to be expert enough to be able to make credible predictions about the cascading impacts of the shock. And this is where the structure comes back in. The HSPA framework and the shock cycle give a structure for the systematic consideration of all the elements. From this, elements that are more likely to be emphasised in the scenario can be identified. And we suggest that people start with the framework and the questions in the handbook and then increasingly tailor them to your own local circumstance. Now, this is going to involve a couple of months of work by the facilitator and their team, where the scenario and all the data that's thought about the health system are considered and refined over and over again. An emphasis on what the resilience perspective brings is really important here. And the shock is useful to promote thinking about what happens over the entire shock cycle and the dynamic nature of how the health system will react. In the end, we know that most participants will spend about an hour or less reading the material that's prepared. And a portion will either be replaced at the last minute or have very little time because they're busy professionals. So plan for that. What we have found is that you need to be sparing and selective about the volume of data that you provide to people when they're participating in this process. But all that information needs to be at the facilitator's fingertips to confirm or challenge what they're hearing from the participants. And as a shock reverberates, it requires different actions to be taken, different trade-offs to be made, and different risks to be mitigated and managed. Assessment benefits from a diversity of perspectives of the system and its strengths and weaknesses, just as responding to an actual threat requires a multitude of people in various places and organisations to make decisions. And when you think about the whole shock cycle that Julia presented, different organisations are more important at different points during the whole shock cycle. So we suggest that you conduct a formal stakeholder analysis and that you, once you've decided what your shock scenario is, to make sure that you don't exclude anyone important. Understanding how the different stakeholders expect to interact will begin to give us a sense of the coordination that may occur in reality. The goal here is to evaluate the strengths and weaknesses of the system, and for that we suggest a voting mechanism, taking into account all of the participants that you've got in the room. We suggest that you include the entire shock cycle in it because recovery and learning are often forgotten about in assessments. Ultimately, resilience testing is only useful if it's tied to some kind of action, which means that results result in an improvement in the health system. We've found that the actual process of undergoing a resilience test with the participants encourages people to actually discuss how their institutions can better work together. Another outcome that we found occurs commonly is that the participants decide that there is a lack of information available about part of the health system, which is crucial to understanding its resilience. So an outcome is actually to conduct further work in an area and then see how that changes the conclusions of the resilience test that you've undertaken. The goal here is to not lose the information that's been generated. So at the minimum, we suggest that the results be summarised about the identified strengths and weaknesses under stress so that they become the base of the next step, the remedial action. As well as the handbook and the website that Julia mentioned, there's a wealth of information out there about resilience on the EC, WHO, OBS and OECD websites. And there are plenty more resources suggested in the handbook, including the work of the ECDC and the World Bank. And as Sandra said, this work all builds upon what was done beforehand, especially that of the expert groups. If you'd like to talk to Julia or myself about this, at this very brief presentation of the handbook, these are our email addresses. And I'd like to say on behalf of the whole resilience testing team, we wish you all the best for your future endeavours in resilience testing. And let's stop and go for coffee and be back at 11. Thank you.
Better say 20 minutes for
10 past 11.
Avoid the hazard that is always
It will be either her full face or her. If you want me to switch back to the slide.
Hello, everyone, and welcome back to our panel. Thank you so much for staying. And my name is Marina Karanikolos. I work for the European Observatory on Health Systems and Policies, and I'm part of this project. Today, with my colleague, Philip Haywood, who you've already met, we're gonna moderate this panel. So now you've seen Julia and Philip presenting the methodology and all the knowledge and evidence behind the handbook. And for this session, we have wonderful speakers, our panelists, and they've actually tested it. So what you heard Phil saying about the 3 key ingredients, you know, the scenario, the facilitators, and the participants. So all these ingredients are right here for this panel. We've done 3 pilots, and although we call them pilots, I have to say there was no cutting corners there. It was full-on proper workshops with all the work done, the research behind it. So we had, the first pilot was in Finland about a year ago, and then the next one was in Greece in May, and then in Asturias in Spain in November. And we chose those pilots because they capture different health systems, also different shock scenarios. So first, today we'll have Elizabeth Diago, a researcher at the IAS Global in Barcelona. And she will be talking about the scenario of climate change in Asturias. And then we have Lilian Vildiridi, and she's the Secretary General for Health Services at the Ministry of Health in Greece. And also from Finland, we have joining online our panel, Soila Karinen from the University of Tampere. Thank you so much, Soila, for joining us and standing in last minute for the colleague Lina Kaiser from THL, who unfortunately couldn't be here. But I also have to say that although we have only 3 panelists, we still have way more people because they represent teams. So the teams of facilitators, the teams of researchers, and also the participants. And if we're lucky, we will have maybe some of the participants joining and contributing online as well. So let's begin with Spain. Ellie, please, can you share with us, what is it like preparing the pilot and doing the research and actually facilitating the workshop and all the practicalities around it, please.
Can you hear me? Yeah. Okay. So thank you, Marina. Thank you. First of all, it was an honor to be part of one of the first pilots, and it was a learning experience that we really enjoyed. So we work at IAS Global, that it's a research institution that works improving global health and promoting health equity through research and translation and application of knowledge. So for us, we also have a preparedness, response, recovery and resilience hub that brings together experts, researchers, and policy experts that work in this area. So the theme of working towards improving resilience capability and health system strengthening was very interesting, and that's why we choose to be part of one of the pilots. And we think that the handbook and all the materials that were developed by you, it's innovative research that was fitting very well with our institution, our areas of work. We thought that having a common framework that is easily adaptable to different contexts, either national, regional, or local levels, it's ideal, and we wanted to be part of the piloting. So when we started planning the piloting at Spain, we thought about what kind of scenarios would be better, and we decided that one that is dealing with extreme weather events
would be very appropriate. At IS Global, we have a research program that works in climate and health effects. We have authored important research that has shown that Spain is one of the regions where we have more mortality and morbidity for heat waves. And we can only expect that Spain will be suffering more frequent and with more intensity heat waves in the coming years. So we decided that it would be good to pilot this scenario in a region that historically has not been dealing with heat waves as other parts in the country. For example, Andalusia, Extremadura, all those regions are more used to heat waves because every summer is a heat wave. But Asturias and the northern part of Spain is considered a climate refuge for citizens in Spain. So we thought that this was an opportunity to test the resilience of this type of region to heat waves. And this had its own advantages and disadvantages because we were the ones pushing the X scenario and the exercise to a region that maybe they were not seeing that a heat wave would be the perceived risk of having a heat wave that is going to strain the health system was not high. So as facilitators, we had to do research on what could be the impacts of this shock scenario and also research on how the different parts of the Asturian health system interact to each other to present the data impartially. And Asturias, for example, is the region in Spain that has the lowest threshold that is considered to activate the heat wave national preventive plan. So this we had to show which data is backing up this lowest temperature in order to trigger this action plan. And this was, we realized from the beginning of our conversations that this could be a point that could bring discussion, and it happens during the facilitation. But at the same time, we cannot push ideas to the stakeholders. We have to be impartial, show the data that is backing up the risk that they could suffer, and bring to the table people that are going to be discussing how the risk, the shock is going to impact different areas of the health system. And what we need to do is show the data, have the data behind, and engage with the stakeholders. And I think now my colleague, Claudia Garcia-Baz, is going to talk a little bit about how this stakeholder engagement worked.
Thank you, Claudia. Please, if you could share with us also about this interesting interaction with the stakeholders.
Yes, like Ellie has said, for us, collaboration with governments and authorities is key for this kind of exercises. We believe the test would be most useful when prepared in agreement with institutions and governments that are actually being tested, and agreeing not only to the scope of the test, but also to the shocks and scenarios used for the test, as our experience has told us. And as Ellie has said, we think that assessing the specific risks that stakeholders are more worried about would ensure engagement and allow them to use the test findings to prioritize actions and identify weaknesses they're actually willing to tackle, and maybe do it in the short term.
Thank you so much, Claudia. And also, I think we have Mario, who is actually a representative of the participants. So maybe we can also have Mario joining us online and telling reflections from his perspective.
Yes, thank you for the opportunity to show you our impressions. For us, it was very useful because discussion in all the panelists were very interesting, and before we were aware that our plan were very accurate, correct, and strength. But in the discussion of the day of the resilience test, it appears a lot of weakness in our planning, in our programming, and it's very interesting to show them. We are very glad to participate in this test day, and we are planning for future actions to improve this plan.
Thank you so much. Thank you both, Claudia and Mario, for these interventions. And in order to save time, we will now move to our next pilot in Greece. But before that, I think it's quite interesting to hear that, in the first instance in Asturias, there was a scenario that was kind of imposed, whereas in Greece, it was the other way around. So there was a good understanding in the Ministry of Health that there is a problem. So please, can you tell us, Lilian, how did that work, and how was it from the ministry side organizing the pilot and working through the resilience testing?
Let me begin by saying that it's truly a pleasure being with all of you here today. So indeed, in Greece, the scenario which was examined was an extreme representation of an existing reality. Very briefly, to give you an idea, Greece holds the highest density per capita of doctors and the lowest density per capita of nurses among EU countries. There is significant health worker maldistribution, which leads to understaffing of primary healthcare and an overabundance of specialties. However, there are still both numerical as well as geographical and a shortage of specific specialties such as anesthesiologists. Hence, the shock scenario that we examined had to do with a massive leave of health personnel. We focused on HRH due to, if you want, a hypothetical scenario of legislative amendments which would affect pension thresholds, salaries, as well as the, if you want, the insurance schemes for health professionals. So we did a stakeholder analysis, and in the pilot, we had representation from government, from the Ministry of Health, including the HR department. We had patient associations, the academics, the people from the academia, as well as the National Insurance Fund and the the Agency for Quality Assurance in Healthcare. And of course, both professionals from both primary and hospital settings, which included doctors, nurses, pharmacists, and of course, management. So I think what the whole day boiled down to the fact that effective stakeholder engagement is of paramount importance when testing a country's resilience to a shock, mainly because the shocks they touch upon many dimensions: societal, governance issues, economic, and they demand collaboration and coordination between all various stakeholders if you want to comprehensively assess the vulnerabilities, and of course, if you want to work on a robust mitigating strategy. Now, in the case of Greece, why that pilot was so important is that services and key organizations actually act autonomously. They don't share data with one another, and of course, they don't embrace a shared governance mentality, which is a huge problem in the day-to-day management and organization of the whole system. So the pilot study was truly a great exercise for stakeholder engagement in Greece. I think we can all agree that all key stakeholders should be involved in the preparatory works of any change or drafting, if you want, an agenda, policy change, a policy idea, just so they have a sense of ownership of the change that you're trying to put forward, in order to also increase the likelihood of a successful implementation in the end. The project truly assisted us on identifying gaps and challenges regarding quality and quantity of data, cooperation between organizations, governance inefficiencies a lot. And the most important thing is that it worked as a starting point. As a starting point for us to act on the findings and work on drafting a concrete action plan to address the problems that I previously mentioned. And as it was also mentioned before, I want to reiterate that the purpose of successful resilience testing exercise is not only to identify the strengths and the weaknesses of a health system, but also to identify and stipulate concrete remedial action for improvement, and of course to address the bottlenecks in health system effectiveness delivery. So in Greece, what happened after the pilot is that it truly triggered a systematic procedure for HRH governance and management. That's why the Ministry of Health has already launched with the WHO a program which focuses on HRH governance, planning, decision, and policy making, with strong engagement of stakeholders from various organizations within the government, the Ministry of Health, professional associations, and of course, the health workforce along the health system. And we're launching also, we're holding a workshop in April for a few days, again, with the main intention of having all colleagues, all stakeholders which are relevant, with the ultimate aim to develop a new human resource information system, which doesn't exist in the country. Of course, in the general collaboration we are holding with the WHO on quality assurance and the different services we provide, and quality installation, if you want, as a point to look at when it comes to health service provision. But yes, I would say that it was a great experience, that ministries around the member states should truly support such actions, and it should become part of the mentality in the policy-making, decision-making process, to include everyone, because in the end of the day, what we should realize is that if you don't have the health personnel, the patient associations, and everyone involved, either it is as a recipient of the health services or as, you know, a daily, someone who works daily to implement what you have instructed. If you don't have everyone on board, then any policy change will be in vain. So for us, it was a great example, and we have put it into practice when it comes to major policy changes that we want to bring forward.
Thank you so much, Lilian, and it's great to hear that the resilience test prompted this kind of shared governance tradition that hopefully gets carried through, and also the action plans that hopefully will get implemented. Also, we are very lucky to have here in the room the facilitators from the Greek pilot, Daphne Kaitelidou, professor from the University of Athens, as well as our own observatories, Dimitra Panteli. Maybe Daphne, would you like to share with us how was it working with the ministry, and how from the facilitator side you can, you know, keep this relationship, maintain independence?
Okay, thank you very much, Marina, and really nice to be here. And I would say that we are thankful to OECD and European Observatory that Greece was selected as a case study, because we learned a lot through that case study, and the model really helped us to make a few steps forward. So it's a provocative question always to ask an academic how were the relationship with the Ministry of Health, but I have to say that we worked very well on that because Ministry of Health respected the need of an independency of the facilitator, and that was for us a huge finding in this case study because Greece is not a country with as Lilian said, with a big tradition in stakeholder engagement. So organizations usually work as silos, and in order to break that silos, you have to gain trust and transparency. And that can be done by an independent organization where, in our case, the background material was objective. And I think that was, appreciated by the people who were in the room. And also, this stakeholder engagement cultivated a culture of shared responsibility and, as Lilian said, ownership of the need to take actions. And transparency is a key word for that, because you have to have all the key stakeholders in the room, but also you have to be, trustful by them. I think it was, for us, it was I think, a successful experiment, and we tried to engage them as much as possible. So we had a lot of voting rounds, and you have to have the right people in the room, but they have to have the opportunity to talk and share their opinions and their point of view, the challenges, the strengths. I think that overall it was an experience that has proven quite useful, and it triggered another series of actions that hopefully Greece is going to take towards the human resources endeavor, which is a challenge anyway. Oh, thank you very much.
Thank you, Daphne. Dimi, please.
Thank you. Just very briefly, also for me, it was a huge pleasure. I am Greek, but I don't work in Greece, so it was a nice opportunity to come back and to work with colleagues. I'd like to take this very important point of stakeholder engagement a step further and say that my feeling was, I had also had the privilege of participating in the Finnish pilot before the Greek pilot, and I think in the Finnish system, this notion we will hear, I think, in a second, the notion of stakeholder engagement and participation in policy development is already the default, I would say, probably. So the experience is that this is a lived experience for people in the health system. Greece, it isn't. Through the workshop, I think we saw that this is something that can be used for capacity building as well in this area. So not just to engage stakeholders in this particular exercise, but also to introduce this way of working for other exercises. So that was really important. And the other thing that I would like to point out, or two things more. I learned from Giuseppe at the observatory. I always take longer than I should in my in my interventions. Very important, the background material that colleagues in Greece prepared, Daphne, Olympia, also with Lilian, because exactly in the siloed context that we were working, it was key that everyone had the same information base to work with and to discuss. So this is something that I cannot stress enough about the success of the workshops. And the final point that I felt in Greece was that we had the Vice Minister herself in the room, who took an big interest in the exercise and was there. And this was great, but it also meant that all these people who were, for some of them, coming together for the first time to discuss a really important issue, had to be able to say their opinion, frankly, in front of the Vice Minister. So this is also something to think about when you plan your facilitation. And I think in this case, the independent facilitators being independent, and especially me being from somewhere else completely, gave me the possibility to go up to the Vice Minister and say, please forgive us if we don't take you first in the rounds, but we need to give people the space to express themselves as well. So just from the experience, a couple of pointers, I think, to take forward. Thank you.
Thank you very much, Dimi. Thank you, Daphne. And now we've heard actually examples where the scenario was kind of imposed on the participants. We heard example of no tradition of kind of working together, but now we're moving to Finland, where all of these things were completely different, because there is a long tradition of trust and participation and stakeholder engagement. And also the Finnish team chose the scenario in consultation with the ministry, learning from the pandemic, but also I was wondering whether Soila Karinen from the University of Tampere, maybe you could share with us how did that go, and whether, because you've chosen, pandemic scenario, it was already after COVID, so did you find that there were any new lessons or kind of reinforcing COVID lessons? What did you get out of the workshop, and how do you feel this work can be now moved on into the future? Please, Soila.
Thank you very much, and hello to everyone. I'm really honored to have the opportunity to share with you some of our experiences. And as said, I'm replacing Liina-Kaisa Tynkkynen, who unfortunately has a force majeure of coming with you today. She is the person who orchestrated the whole Finnish pilot and chaired the day, while I was in charge of facilitating and organizing the facilitation. And as Marina said, there was a really big group behind all of this as well. So it wasn't just the two of us. There was a lot of work, but I personally think it was really worth it. And yes, we could draw some lessons learned, both from the pilot itself and also from the COVID-19, which was related because we chose the pandemic scenario. We planned the scenario to be a little, and perhaps a little more than a little, different from the COVID-19, in order to help the participants to discuss also some other aspects of pandemics than what we saw in COVID-19. But in a whole setting, the participants that we had, actually 18 different sectors at place in the pilot day, they were very grateful for the day, and they saw it as very useful exercise and expressed gratitude in words as well. And it seemed that they did actually use it also as a platform for doing some sense making over the COVID-19 and drawing lessons from it, and kind of inter-crisis learning processes there. What we saw actually was that they were able to provide some new ideas and new thinking in a different level than what we saw in the formal and normal discussions. They were talking quite a bit on values and human rights and constitutional aspects. And we did have people from health sector, we had social sector, we had children's rights, also they're participating and so on. So we had a kind of a cross-sectoral discussion. But I'm really enthusiastic to hear from Greece and Spain that how has it worked after that, as in Finland it was more of an exercise that was kind of separated from the normal system, but it was very fruitful anyhow. And just to answer one of the questions in the QA, if I may, as I told, we had different sectors present in the pilot day, but unfortunately we did not have NGOs or citizens participating at this one, even though we do have a history of participatory work. But there was a question of big or small groups, and we used this Me, We, Us facilitation tool for enabling a more balanced contribution from everyone. So everyone would be divided into smaller groups, and first having a little moment for themselves to ponder on the questions that they were going to address. Then they would discuss in the smaller group, and then in the end, the chair, Liina-Kaisa, would invite everyone for a roundtable discussion. So always you don't have to decide between big and small groups, but you can figure out a way to have room for everyone to contribute. And I think this was a very good way of making people who might not usually be as active as some other participant to be able to participate in the discussions. And one more lessons learned from the team was that, as Phil already underlined, that the scenario building should be very, very thorough, I'd say. We did get some critique from our scenario, and we found that we need to clarify even further the purpose of the testing, that it's not a simulation exercise, rather than it should be more of a general examination of strengths and weaknesses, and also, as was mentioned, that what should be done in order for us to be more prepared to something that we don't know what's coming up. Secondly, I want to bring on some ideas on what would be the potential for applying these resilience tests in a range of shocks. And after experiencing only one testing and now hearing from other countries as well, I personally believe that maybe a series of tests on different scenarios might help the stakeholders to identify more strengths and weaknesses, and also some patterns and processes within the system that might work in different scenarios as well. Or they might enforce the findings that we drew from the one resilience test, and maybe in that way build more credibility in the eyes of, for instance, policymakers when we communicate our results on the resilience testing. At least in Finland, politicians and other stakeholders often want to have lots of information, and I believe they prefer robust and numerical data, and therefore maybe this range kind of thinking might be fruitful as well. And then again, what we lacked in Finland, in my opinion, is that, as I said, it was kind of a separate pilot exercise. If we would want to make some changes and maybe facilitate new kind of thinking in the system, we think that it would have to be regular. If there would be regular tests, for example, they should be implemented in the policymaking processes. For example, it might be useful to build them in the system where, for example, legislation or other parts of impact assessment already is in place. We have when we do legislation, we have a rule of circulating the proposals for comments. So maybe resilience testing exercises might have a place in there, or before we have the proposals in the circulation, we could see these tests as part of impact assessments, which are also compulsory in Finnish legislative work. What I see as limitations, though, is the timetables, which we already had some problems, even though we had only the 20 or so participants. And also we would need to communicate the purpose of this resilience testing to those involved, to make them see why this should be done. And last of all, I still want to underline the issue that already was here said many times, but I feel that we, or whoever would be running these resilience testing exercises, should pay really much attention to identifying the people who are invited to participate. There's lots of power, and we should have also responsibility over that phase of the testing. So that's my takeaway for now. Thank you.
Thank you, Soila. Thank you so much. And thank you to all the panelists. And I have to say that we worked very closely with the facilitators, with the researchers, with the participants. We gather all the feedback. So this is why this book is so big, because all these takeaways, all these lessons are actually in the book. We worked through the process with them. So thank you so much again for staying with us for over these many months and responding to all our questions. And now let's hope that we've convinced people to use this, but I'm handing over to Phil for the discussion, please.
Thank you, and thank you, Marina, and thank you, everyone. I'd just like to echo what Marina was saying about the facilitators being the engine room of what's going on with the resilience test. So this is a chance where you actually get to ask some questions. Please, as usual, introduce yourself. If you've got a panelist that you'd like to talk to, name them. But we might start with an online question first from Norway.
Hello. Hello. My name is Ingrid Sones. I'm from working at the Directorate of Health in Norway. First of all, I just have to say how overwhelming all this work you have done is. It's quite impressive, and I'm so happy that you finally have like a, not you finally, but there is on the table now a book about resilience testing within the healthcare system. Because I think in Norway we have tested or stress tested or preparedness testing of health system in the larger sectors for a long time. But this is, I think it's like, it sounds like it's the first time you get a sector specific health system or resilience testing. And I think that's really, really good. My question, I think, is thank you to Finland for pinpointing the point with the stakeholders and the efforts that you put. You said you had 18 different sectors. Did you, was that all healthcare sectors from the different regions or municipalities, or was it primary care, specialist care, or was it different sectors as well? That's the first question.
Thanks. Did you want to take this, Willa?
Thank you. Thank you for the question. We did have 18 participants in total. During the day, we invited some more, but they had some obstacles of coming to the place. We had different sectors. We had social sector, health sector, and we had also kind of different levels. We had national and regional. We had secondary care. Maybe not primary care. I come from primary care myself, though, so kind of there. And we also had the children's ombudsman because the pandemic scenario was one hitting especially young children. So we wanted to have some discussion on children's rights. And what else? Well, plenty of people. We had doctors, we had some with nursing background, and also lawyers and so on.
Perfect, thank you. I might get you to hang on the line, Ingrid, while we take some questions from in the room as well. So I think there was a gentleman down the back with a question.
Thank you very much. I want to congratulate the Greek exercise on human resources a bit, because I think it's key. And of course, if you make this kind of analysis, there is a lot of consequences for the government to act. And especially I appreciate so much that there is now an activity to rebuild and reconstruct and strengthen the training of family doctors in Greece. And I'm so happy that I'm invited next month to come to Gallina, because there we are going to try to build from our expertise that we have in other different countries, a kind of network for improving the training of family doctors. And this is so important that this analysis is a starting point for really making fundamental changes that will not only better prepare for crises, but that will strengthen the primary health care for the population, and that so will also be translated in health gains in the daily practice of the functioning of your health system. So I want to express my appreciation of that and illustrate that it is not either preparing and resilience for crises, it's or building strong and better structures and training and capacity. It is the both together, because the one helps to strengthen the other. So my congratulations and appreciation. I look forward to see you in Gallina next month.
Thank you. Did you have anything to react to?
Well, I wanted to say that indeed we are in a process where we're trying very constructively and in a very organized manner to see what to do with HR management governance in the country. Of course, yes, there is a focus on primary healthcare in order to attract family doctors, because I'm sure everyone who's a bit in touch with the Greek reality and the Greek healthcare system, you know, we don't have a primary healthcare system which serves as a gatekeeping mechanism for secondary care. But I would like also to stress on that the effort is quite conscious also on HRH management and governments and hospitals. As I mentioned, we don't have any form of systematic record. We don't have data, not even quantitative, but qualitative as well. So right now, for the first time, and we were discussing this with the team last week on a Zoom call, for the first time, we announced job openings, 2,147 nurses and 7,000 doctors to fill hospital positions. And for the first time, they were based on an analysis with KPIs, taking into account, for example, the occupancy rate in a hospital, hospitals which are in proximity and they offer similar, if you want, services or have similar clinics. And we put a benchmark for the first time. For example, we all know that for a clinic, we take 1.8 to 2.1 nurses per occupied bed. So we take into account occupancy rate. So we're trying, at least slowly, with any permanent hiring we are doing in the system, to, if you want, go closer, one step closer to a benchmark. So at least the 127 hospitals we have are at least staffed appropriately, and always taking into account the services they provide, the people they see, and have a well-rounded approach to that. So this is something that the pilot also triggered, and more so, it triggered the understanding from the point of view of the stakeholders for the need to do so, which also I know the team can remember the difference between their first responses and their final responses. You know, our key stakeholders, which are key organizations which support the NHS in Greece, they thought that we have an abundance of data, but the quality was the problem. And then in the end, after the whole day of the workshop, they recognized that no, we don't have data. It's not only the quality, it's the quantity, because everyone would see the system from their own sphere.
Thank you. And it's such a wonderful story of how the process works to generate action. Again, in the room, the lady in the fourth row back.
Ilaria Giannico from the European Federation of Private Hospitals. I have a question for Greece. Did you involve private hospitals in your exercise? And if yes, did you notice any major difference between the public and the private? Thanks.
No, we didn't. Actually, we didn't involve because the NHS and the HRH planning that the ministry does is only for the 127 hospitals in the country and the 300 primary health care units. And actually, you know, the issues that we face, for example, I mentioned earlier on specific shortage in specific specialties, for example, anesthesiologists. Yes, we have a shortage as the NHS. The private health system has an abundance. And we don't have the synergies to cooperate at this point in time, which is, of course, something that we're trying to attain through legislative amends, you know, public partnerships, not only in infrastructure, not only in service delivery, but potentially in HRH overall.
Thank you, Lillian. And we might take a couple from online if there's any that you particularly wanted to bring up.
Very much along the same lines as the discussion in the room. So I think we're good.
That's great. I know we miss out the online people if we're not careful. Sorry, I saw two hands go up at the same time. So the lady in the back row, and I've spotted you as well, sir.
Good morning. My name is Claire Champex, and I'm representing Eurocarers, which is an organization gathering informal carers, grassroots organization, and research organization focusing on care and long-term care. Thank you for all the presentation. I think it's a very fascinating tool that I will certainly talk about. I was wondering if in these exercises you did involve or came to a point where you discussed the question of informal care and informal carers, knowing that informal carers, also called family carers, are playing a key role in supporting patients, especially elderly people and people with chronic disease. And they are both part of the health and long-term care system and also a vulnerable group because of the stress and burden that they carry with them. So that was one question. And also, well, maybe it's for future follow-up of the exercise, how could you link it up with the ongoing reform in long-term care, which are supported by the European Commission through the care strategy and European funds, and how the dots are connected between this health area and the more social and care policy area? Thank you.
Thank you. So Sola mentioned about the issues with the Children's Ombudsman and involvement there. Did you want to take this, Elizabeth? Yeah. And if it's okay, we might leave the second question in the interest of time.
Yeah, so for example, in our scenario, elderly people are one of the most vulnerable people for heat waves. So we included in our table the social services that are managing nursing homes, daycare for elderly people, in order that they bring us their perspective on how well they are prepared or what plans do they have for heat waves. So they were included in the table, and they actually gave us really good perspectives in the region on how well they were connecting the health system with the social services when the alarm is triggered, the threshold is triggered, or what kind of plans do they have in order to protect the more vulnerables. And also informally, because there are people that maybe they are elderly people that they are living alone and maybe they don't have a network of a health system that is taking care. So municipalities, they saw that they have a system on how to try to connect when there is a heat wave with those people in order to make sure that they are doing well. But it stressed their need of formal plans for reaching out the most vulnerable people that maybe they don't have access, near access to healthcare in the region.
And so we'll have the lady in the fifth row back and then the gentleman at the end. And I'm sorry, I think we'll run out of time before we get to you.
Yes, hello, I'm Linda Zoikeli from the Ministry of Social Affairs and Health in Finland, in fact, so I thought I would also react to what Soila was just talking about, resilience testing in our country. In fact, we do have a lot of resilience testing going on, and it increased exponentially just now as we joined the NATO, and we had to start doing intersectoral resilience testing on many topics. So in fact, in November, our ministry, which is also responsible for water safety, decided to do a resilience testing speed dating version, and we had a half-day version of this kind of process, and we actually received a lot of positive feedback, because this meant we were able to get all the other ministries and the other sectors involved despite their very, very busy schedules. And in terms of how quickly we can get from resilience tests to real action, in fact, the latest resilience tests we've been doing across sectors where health in all policies is always present in the discussions, we are currently writing legislation to streamline our health systems governance in crisis situations. So we have realized from the different tests that we always get the same result. We need to have a different kind of governance system in the crises. So we are writing that right now, and it's currently being commented in the public. Thank you.
Thank you. And it's really interesting to hear about that cross-sectorial innovation, something Francesca was talking about. And I believe there's a gentleman in the back row who had a question. Sorry, third to back row. I need to put my glasses on. Awesome.
Hello, my name is Guillermo Hegel. I come from the Institute of Tropical Medicine. And currently we are developing a project related to mapping data for urban health, and scenario testing will be part of it. So I was wondering, it was mentioned that there were different types of process to develop the scenarios. One was the imposing the scenarios, and the other was the co-creation part, like developing the scenarios with the stakeholders. So what were the benefits and drawbacks of the different models, and what lessons can we learn out of that?
So it kind of cuts across the panel, and I think we've mentioned some of it, but Lillian, did you want to take the co-creation? And then Elizabeth, did you want to take the imposed version?
I think for us, having all the key stakeholders that, they have to implement policy on a daily basis, and they have to come into reality and to take everything into account was truly important, because we realized the lack of information, of common information between key organizations which run the system, key service providers. So for us, that was major thing, because we realized where the information and the process lacks and what we have to do to enhance the flow, the processes that are necessary to be in place. And of course, from the findings, which was not your question, the process that we have to in general set in policy development. But I would say, if we had to do it again, I think we would bring everyone in the same place. Is it the ministry? Is it health personnel, hospitals, primary healthcare, everyone, and not only management, but doctors, pharmacists, everyone that has an independent role in the system. Patient representatives, I think that's key, because they are, in the end of the day, the ones that can assess the health services that you provide, and everyone who's involved, such as quality agency, insurance fund. I think if we had to do it again, I'd do it that way.
Elizabeth?
Thank you. Okay, so I think in our case, when we imposed the scenario, we realized also by the beginning of the conversation with our stakeholders that they were very lacking of the interest, because maybe they thought that a heat wave was not a risk, and that the chances of the heat wave to have an impact in their health system were very low. But I think after conversation during the day happened, they realized that they have a strengths, like a huge opportunity by other crises of rapid response and bringing resources to the table to tackle the problem. But they realized that they had other weaknesses that I think at the beginning of the day they didn't have. So probably if I think if I have to repeat it, probably I will have more meetings before the workshop in order that we present the data, why we are thinking of doing that. But I think it was an opportunity for them to realize that even if the chances are low, they are still there and they are increasing over time, and it is something that they could act on, uses the strengths that they were found out to tackle also the weaknesses that were found out. So that would be my take.
Perfect. And Soila, did you want the last word?
Thank you very much. Actually, I'm quite in line with the others on that. participating also in building the scenario and building the testing is very important. We got most critique from our scenario on details and less details, and one person wanted more detail and one less. So in order to build it in such a way that it's understandable and includes those things that are needed for the discussion is very important. And I think I would also do more collaboration in beforehand than what we did now.
Thank you very much. So we're out of time now, but I hope you all see how important it is to actually develop what you're going to do in the resilience testing over time and how incredibly important both data and people are to doing things. I'd like you to join with me in thanking the participants for all the time they spent actually working on this and then giving up their time to come and talk today. Thank you very much.
Hello, don't go away just yet. It's time for panel 2. So I was thinking maybe everyone, we could stand up if you're in the room, because panel 1 went longer than before. Inez Viva feels very, she needs a stretch. So everyone up please, and we'll bring the panel up at the same time. It's good, maybe like reach for the sky. Giuseppe, yes, very good. Careful with those laptops. Those are WHO. Okay, you can sit back there. Yes, please can stretch. Sorry, you can stretch. And actually, yeah, if you feel so inclined during the panel, please stand up and stretch. If you were at home or at work, also I hope you took the opportunity to stretch. We could do the whole thing. I have a standing desk. We could do that. So we've heard how the resilience testing methodology works. I hope by this point you're convinced this is a very doable exercise. So it's a big book, but like we said, we have a lot of scenarios in there. It's a lot of examples. It's actually a very doable, a very feasible project for a country or a region to undertake. The purpose of this panel is really to understand a bit better, okay, so why do this? What's the value of doing a resilience test? What can it tell us? How can it support national policy dialogues, help to identify blind spots in preparedness, and bring stakeholders together? So this is going to be co-facilitated. Phil doesn't get to leave very much. He came all the way from Australia, so he has to make it worth it. So I wanted to start, Gintaras, with you. So Gintaras is the director of the National Health Insurance Fund in Lithuania. And I want to go back to the financial crisis to start of 2009. So in your view, for the health system, for the National Health Insurance Fund in Lithuania, what worked well during the financial crisis? And is there anything that Lithuania learned from that experience with the financial crisis that was applied to the COVID pandemic?
Thank you. Hello, everyone. First of all, I would like to thank you for invitation to this very interesting event, for possibility to listen in science for the first panel, for presentation of pilots. It's really very interesting, and also possibility to present some experience of my country, Lithuania. In Lithuania, we have a so-called national health insurance system, where half of population is paying insurance contributions, and the other half of population is not paying because the government pays on behalf of them. The important thing is that the amount paid by government, which is consists like 1/3 of total income of health insurance fund, is linked to the amount paid per one person. Of that, 50% of population economically non-active is linked to at that moment was linked to the official average salary of economy of year before last year. And this mechanism, which is set in law, gave us two positive things. One thing is that when economy is growing, the amount paid per government is linked and is growing with 2 years lag, but is growing also. But when crisis comes and there is decline of contributions of economically active population, then the part of government is still growing 2 years. I would like to use the opportunity to say my compliments to people who were designing and adopting this mechanism. I was not among them, but I am proud of them. Yeah. So when global financial crisis came, it worked positively for us, and I have diagram now in my head. When I see two lines, one line, it was amount of contributions of economically active, which dropped in 2009 in Lithuania, 9 and 10, but the other line, contributions of government, was still growing 2 years. So this helped us to mitigate some losses. I would say some losses that didn't save us fully from the cuts. So we had to decrease medical, because of austerity measures. We had to decrease salaries of medical staff by little percent. We postpone innovations for a couple of years at least. So it was quite tough period. But our main goal at that moment was to maintain accessibility. And we were successful in this. And interestingly, even out-of-pocket payments didn't increase during that period. But our providers, they had some savings before this crisis. We were doing relatively well 2 years, but after those 2 years, they started to demonstrate red figures. So we were a bit ready to that crisis, so to say. And coming to pandemic crisis, if I may continue, we had this mechanism in place. We also had some reserves, like 15% of our fund reserves. But of course, the shock was so huge. Health insurance fund continued to cover running costs, plus additional payment to medical staff. Our government put quite big money to this, masks and other measures, then tests, vaccines, and so on, so on. So money was not a big problem during pandemic crisis, but if you even look at our statistics, you will see that 2020 and 2021, Lithuania had as a percent of GDP, public expenditure on health as a percent of GDP higher than any year before. But after in 22, it dropped again. So money was not a problem, but we had a lot of other problems. I will not be counting them, because I believe all of you know all this problem of hostel beds, all this recruitment of medical staff, and so on and so on. So we were like a bit ready to that pandemic crisis, but and money was not a problem. But for instance, if we take such indicator as mortality, we were really not doing well in this respect. Therefore, I think pandemic is over. Now what we are meeting all our countries, we meet this so-called post-pandemic things, yes. And we also, many of us probably, we have feeling that some new crisis is behind the door. So I think what I hear today, and this perfect job done, is really very useful. And I really would like to use opportunity to thank all who initiated and made it and presented. Thank you very much.
Thank you, Ginteras. And just to ask, So obviously on the revenue raising side, like you said, Lithuania was very well prepared. Are there mechanisms that you've used previously in Lithuania to try and more prospectively identify these blind spots, or is something like this tool that we've presented today very unique from like a Lithuanian perspective?
I would, if I may respond, we really, yeah, we had a kind of mechanism, counter-cyclical mechanism, who was helpful for us, but we never look at this preparation to various crises in a systemic way. So this instrument is really thing to do in systemic way. So that's very useful.
Thank you. And if we may, could we turn to you, Nestor? Nestor Afonso Santa Maria is a senior advisor in the OECD High Level Risk Forum, and that's part of the governance directorate of the OECD and deals with multi-sectorial risks. So basically, Nestor, this is your foray into health system resilience, but what are the major lessons that you would take from your work across multiple sectors to strengthen health system resilience? And picking up on something that was mentioned earlier by Dirk, you were responsible for the Belgium report that the OECD did. So what were your biggest surprises and takeaways from that as well?
Okay. Thank you, Phil. And thank you and the team of the Observatory and the Health Division and the OECD for all the work, and thank to the countries that lend their efforts to actually be part of this work. I think one of the key lessons that I guess we could draw from the experience with multi-sector resilience and how it impacts on health sector resilience is that it's very hard to pin down what specific thing you will measure to be able to be safe against the crisis to come. And if there are two specific things that you might want to look out for, the first one is, I think we already heard it from the first panel, and the extent of your inequalities, the extent of your vulnerabilities will be a determinant factor. And we see it time and time again, and it shouldn't be a surprise that those most vulnerable are the worst hit by any crisis of any nature. So you need to be thinking about how you will mobilize your system to be able to address that challenge, because it will come inevitably. And the next bit is, so that's a bit that you can know. And the bit that you cannot know, you should also prepare for. And I think that's being able to prepare to fail. And I think we also heard it a few times before. It's being able to flex your system. Systems that have the ability to adapt to the conditions that are presented to them are the ones that are able to actually mobilize resources, being able to have a contingency fund that, even if it's only part of the expenditure that you're going to need for addressing the crisis at hand, is a really important tool for this kind of thing. And I guess the next bit, and here I'm sort of starting to link to the second question that you ask. You have to make friends before you need them. And I think this is really, really absolutely essential. And I think I was super happy to hear the experience of Greece, of like actually bringing everyone together with the conversations that we had, not just in the Belgian review, because we also did an evaluation of Luxembourg's COVID response, and the two together were really interesting, kind of very different contexts, very different outcomes, very different challenges. But the thing that was definitely consistently happening was a realization that if during a crisis is the first time that you're sitting down with your partners, that's too late. You've missed a trick here. You have to sit with them beforehand. And being able to use the opportunities of stress testing, of exercises, of planning the exercise together, of planning the stress test together, of evaluating how the stress test is working. I think those are key moments to build the relationships that will make your system more adaptable and more able to cope with the crisis that comes. And I think the last bit that was really, really important key message from our perspective in particular is that, yes, health is important for all policies, but all policies are also important for health. And you can actually learn from other sectors, and you can actually teach stuff to other sectors. So I think sometimes when speaking to colleagues in the health sector, and I can say that because I am not in the health sector, so no one will crucify me back home. But it's really hard to get colleagues in the health sector to listen to others outside of the health sector about challenges that are presented to the health sector. Do you listen? So I think being able to understand that the relationships that you will need go beyond the health sector, that the solutions that you might need to draw upon also might go beyond the health sector, and that because of that, the friends that you need to make before the crisis also go beyond the health sector. I think that's really important. It came time and time again when we were looking at the Belgian system for their COVID response. It came time and time again when we were looking at Luxembourg, and it comes across all of the systems that we look. If you have a system that works properly, it is a system that is challenging itself to speak to those that it doesn't normally speak to.
No questions yet. Come on, there's an agenda. Thank you, Nestor. It'll be interactive, I promise. No, thank you, Nestor. We'll just keep going on the panel, and then we'll open it up for questions. I promise, Boris. So Mike Stoto, Professor Emeritus at Georgetown University, who's traveled the second furthest distance besides Phil to be here. So Mike, so you've worked in many contexts on preparedness and resilience. How do you see the handbook being used to complement the current suite of tools that are available at national and international levels?
Well, thank you, first of all, for inviting me to come here, and also to the team and the countries that work together to prepare this this handbook. So really, for the last 2 decades or more, the world has been focused on the question about preparing for pandemics. And following SARS 20 years ago, we have changes in the international health regulations. And there really have been a number of ways to address the question, are we prepared? That includes the state parties assessment annual reporting tool, where countries report to one another about holding one another accountable, and then things like the JEE, the Joint External Evaluation Tool, to improve quality and to guide improvement. Now, SARS got us to ask the question, well, were we prepared? But I think now we're turning our attention to the question, are we prepared for the next one? Which we don't know quite what it will be, but we need to really focus on that. And so I think that Europe has really been leading the world in this respect in a number of regards. Most importantly, the changes, the new regulation 2371 on serious cross-border threats to health that was passed at the end of 2022, and also the revised mandate for ECDC. There are 3 things in that regulation I want to mention. Article 7 that talks about the revised triennial reports, which that countries have to do, and that's a kind of objective, self-reported way of doing it. That's an expansion of the WHO SPAR in a lot of respects. There's Article 6 that talks about the need for national prevention, preparedness, and response plans that are intended to be coherent and coordinated with EU plans in the work of the Health Security Council and other member states and so on. And Article 8 in particular, which is a new process for external assessments of member states' implementation of their national preparedness and response plans. And this is the context in particular, I think, that the new tool can be responsible. It's a tool, first of all, and most importantly, for member states to use to evaluate their own systems and to find the gaps and to improve them. Again, evaluation is the first step, but addressing them is really important. And that is important for their own country's benefit, but it also feeds into their responsibilities to the global community. And I also think tying it back to Article 8, I think it could be one of the things that is considered in those external evaluations. Now, I do want to make a comment about the word health, the phrase health systems. I think that everyone has mentioned that today, and I also think that everyone in the room has a different concept of exactly what that means. And it came up in your response in particular. I think it's really important to just be clear about that. There's no right answer, but we need to be clear about that. To those of us who sort of came up in the public health world, we tend to think in terms of the way the WHO describes the whole of society response. I think that we saw this in particular in the example from Finland, where that really was represented here, and I think to some degree in Spain as well. I think the new report tends to be focused more on the healthcare delivery system per se, and I think that really came up in the Greek experience, in the Greek example. Public health functions, of course, come in to that, but they're treated as, to some degree, external to the healthcare delivery, delivery system from my perspective. So again, there's no right or wrong answer, but I think it's really important that we be clear about that. And bringing it back to the practical realities, I think there's two opportunities in the process where that can be done. One is developing what is really the scope and the aim of the exercise. And I think that we saw that in the examples that we heard about this morning. And secondly, deciding who's going to be the participants. And both of these, in a way, implicitly define what the health system that we're talking about. One more comment, that the Regulation 2371 also talks about stress tests at the union level. And that has not been the focus this morning, but it seems to me that the toolkit is a toolkit. It's a qualitative method that might also have some relevance in that context as well.
Thank you. And could you talk a little bit more also just about the way you think the methodology could be used to identify weaknesses in health systems, and especially how to address these weaknesses and improve resilience? You know, I know we talk a lot about things like the Health Security Index and the findings from that pre-COVID, which suggested that countries like the UK and the US were very well prepared to deal with the pandemic. I mean, how do you see this type of exercise really feeding into the knowledge base in terms of preparedness and how countries can adjust their...
I think you're referring to is an analysis that my colleagues and I published last year, where we were noting that about half a dozen different papers have said that things like the Global Health Security Index and so on didn't predict COVID outcomes. And there were a couple of problems with that we found. One is that the data that they looked at were very narrowly defined, deaths in the first 100 days and so on. The analytics were simple cross-sectional analysis. But more importantly, I don't think they were asking the right question. The question about that we want to focus on is not predicting the outcomes. The question is, are our systems prepared? And what can we do to improve preparedness? And I think that gets at the question about governance. And I think that one of the things that we've learned is how important governance is. And we heard about that in the first panel this morning. Governance certainly includes what high-level policymakers do. And we have certainly sad examples about that in the United States I won't dwell on. But it also includes governance. Basically, how do we get the system to work together? And the system, at that case, means things about across sectors, and it includes at the different levels, at the national and the regional and the local level, but also going up to the European and the global level as well. And I think that one of the things that we found looking at COVID was, when you looked at surveillance and testing, countries all had a surveillance system in place. The question was, could they scale it up? Could they scale up the testing? And could they organize a new reporting system across a lot of different jurisdictional levels to work? That, I think, is what resilience is all about. I think that's what we need to really focus on in doing this testing.
Thank you. That's fantastic. And we completely support the idea that the toolkit is scale neutral, like it's just a toolkit. And so now we might move on to Nathalie Berger, who is the Director of DG Reform. And you've heard a lot today about the manual and resilience testing. From your perspective, what is DG Reform doing to support the resilience of health systems? And how can you see this type of tool being useful for DG Reform and the Commission more widely? Thank you.
Thank you very much. I was listening to the previous speakers and trying to draw some connections and maybe look at the issue of health, resilience and testing in a wider context and the context of crisis. I have witnessed the financial crisis, the great financial crisis, and contributed to a number of measures in response. And I was thinking when Gintaras was talking about the national health insurance system, and I could see some connections between the different sectors and maybe a pattern to follow, which is, of course, to start by stress testing. Stress testing was introduced in financial services area, and the banking stress testing are quite famous after the crisis. But in 2019, in March, we suspended the stress tests. We did not take them. We did not do them. Why? Together with the European Banking Authority and in cooperation with the European Central Bank, etc. Why? Because the reality coming from the COVID crisis was outpassing the stress test scenario. So I think this is a very important lesson to take for the future, and I see a very strong added value in the handbook that has been prepared on resilience testing. And there we can draw the lesson, or we can draw the parallel with cases of civil protection, crisis management, and of course health. So we have the issue of resilience testing, and we come to the topic of health systems performance assessment, which are very important to ensure, I mean, to come very close to the concept of a stress test, and to ensure that we build afterwards some resilience. So I would see, you know, if we try to build up a process, maybe the first phase will be the topic of health system performance assessment. And there in DG Reform, we have done a lot of work. We have supported 7 member states since between 2017 and 2023, Croatia, the Czech Republic, Estonia, Ireland, Latvia, Lithuania, and Slovenia. We've supported them to set up their frameworks, their tools, and their methodologies to assess the performance of their health system. And as you have outlined it yourself in the handbook, the performance assessment frameworks are very important tools for evidence-informed policy making, for identifying the strategic priorities. And this is something that we really need to do more in the European Union, to monitor reforms and to ensure accountability. And in the long run, they are absolute key enablers for making the health systems more resilient. So that's, I would say, step 1, test and do the health system performance assessment. Stage 2, invest. Invest in health systems, invest in hubs, health hubs, and that's where I would like to come with the project that we are conducting now together with the technical expertise of Expertise France and of the Health Observatory, which is extremely important. The Resource Hub for Sustainable Investments in Health. What is it? This is a project that is being led by the Belgian presidency. We started under the past Slovenian presidency and with Austria, with the objective to enhance the capacity of the ministries of health to make the case for health investments vis-à-vis the ministries of finance, We help them to test more strategic solutions for investments, for example, through a pilot on the greening of hospitals. And with this project, we informed the design of a concept for a health reform hub that could serve all the member states. So we have there the possibility to connect the dot, not only to facilitate the investments in health, but also to get the different member states to talk to each other when they consider investing in health. And investing in health also means beefing up the health systems. And there we have done a lot of work to support member states, notably with the introduction of multidisciplinary integrated primary care units. And I can give the example of projects in Belgium, in Austria, Slovakia, Estonia, and Spain. And we've also worked on promoting coordination and collaboration within the sector and with other levels of care. And I would like to highlight in particular the example of Austria, where we have supported the setup of integrated primary healthcare units. And these units are now being rolled out at national level. And this is done in the context of the Austrian National Recovery and Resilience Plans. And we are very pleased to have contributed to the initial stages of a very successful reform there. And then we could also think of other sectors. And I'm thinking of another topic or a link that I haven't heard raised, but is, I think, extremely important, which is the connection with the climate resilience. Climate crisis and the interaction in between climate crisis and, of course, health and health crisis, both are linked. And there as well, for example, we have a very important project with the Greece Ministry of Fight Against Climate Change and Civil Protection, where we provide assistance to really establish a structure that is going to be extremely strong in preventing and addressing risks in the area of climate, but climate having an impact on health, everything is connected. And this may be my last word. Think wide, think connected. Health needs finance, and health also will be impacted by the future challenges that we're going to face collectively.
Thank you very much for that. I mean, that's fantastic and circles back to where we were at the beginning, which is that everything is connected and that we also need to make the case about how we're going to invest and what it means to actually have the evidence to encourage people to invest in what we need to do. I'm going to turn to the audience now. I know... Yeah. Yeah, that would be fantastic. Is Steve Thomas online? Thank you. As usual, introduce yourself and the question and who you'd like to direct to, and other members could jump in.
Hi, Philip and John and everyone. Great to see everyone there. This is Steve Thomas here from Trinity College, Dublin in Ireland. And I'm just interested on the whole question of muscle memory and the whole question of collective decision-making and reflection. And I think it's picking up on this idea of building relationships. And that's why I think this kind of stress testing scenario is, and scenarios and decision-making is extremely potent for looking at health system resilience and also for looking at reform and policy direction, because it's getting quite key central people in the room to build that muscle memory, if you like, so that when a disaster hits, you've been through the process, you're practiced at looking at the data, you're practiced at thinking about what your objectives are, and you have collective collaboration. And one of the things that we've certainly looked at in Ireland is that we've been through several crises and we've tried to leverage them for reform, but I sometimes wonder whether we haven't had quite the right people in the room. And so I think that this kind of stress testing scenario could be extremely important to doing that. But how do you get that right balance, I think, between people who will like go with you or you know, and collectively make decisions for the common good, or where people might tend to push towards their own self-interest. So I think that there's a balance in there, and I quite like the panel to kind of reflect on that tension between the collective problem solving and the self-interest of some interest groups.
Thank you, Steve. Nesta, would you like to take this, and then Mike?
Thank you, Steve, and really good question. I think here I'm going to draw heavily on the experience of the Belgium and the Luxembourg review of the COVID response, because one of the things that was challenging at different moments, particularly in Belgium during their COVID response, was that the traditional consensus-based decision-making model that is what most of the governance in Belgium is built upon, had cracks and didn't quite deliver what they were expecting it to deliver at different moments, and it was very challenging for them as a system to be able to not be able to rely on consensus for something as dramatic as COVID. Eventually, it did deliver, and it did come together and enable them to make some really important decisions that sort of eventually sort of made the response be back on track. But I think being able to have, before the crisis hits, explicit conversations about how you will have a system to handle these lacks of consensus, to have the opportunity to actually explore what is it to make decisions without all the facts? What is it to make evidence-informed decisions when the evidence is flaky? What is it to make decisions in uncertainty? Because these are the things that you'll have to do in a crisis, right? So if you're not able to, before the crisis hits, have a system that is actually rehearsing how you do it, have the players that will be doing it play how you will make these decisions in the absence of kind of concrete evidence, or how you will select the things. I think it's really, really difficult to do so. But at the same time, I think, and those of you that have worked with me, you know that I'm sort of civil servant from the UK, on secondment to the OECD. I don't speak for the UK government, but I do draw on my experience from that. And I think one of the things that the Chilcot inquiry into the Iraq war did come up quite strongly is the importance of avoiding groupthink. And I think it's not just sort of having the players and having everyone to, but really being open to dissenting voices. There's nothing harder than having a conversation with someone that doesn't agree with you. It doesn't feel right. It's not pleasant. It leaves you with a bad taste in your mouth when you finish it. But for decision making, it is essential. And these uncomfortable conversations are absolutely essential for guaranteeing the quality of the decisions that we make. And the quality of the decisions that we make in a crisis is really, really important. So don't always only invite your friends. Invite everyone that needs to be part of the decision. Agree in advance what are the criteria that you're going to use to arrive at the decision. And then bear through the pain, because the interest is the greater good. It's not you being comfortable, it's not you liking the decision-making process, it's actually delivering something that delivers better lives.
So I want to agree with all that and build on it. I think that one of the things in the question really had to do with the dynamics of the people involved, both in the decision-making and in the analysis process. And I think that there's two things that can help. One is having a formal process for doing this. I mean, we see this with after-action reviews and so on. Sometimes just the boss comes in and says, well, this is the way it goes, and no one else can talk. But having a formal process where you have to kind of think things through in an organized way, which this tool gives us, is one. The second one is having some degree of independence. And Daphne, I think, spoke about that in the Greek experience as the facilitator, being able to do that. And I think that's important. But I would also raise the issue about whether you could have other external evaluators, other external participants, I should say, not evaluators, involved in the activity. You know, sometimes they can just sort of, you know, raise their eyebrows and say, "Really? Do you think you could do that in practice?" And that's the kind of thing that's necessary. In the JAE process at the WHO, we've seen that in other examples as well. Getting external people can just bring some credibility and just sort of raise those questions.
Absolutely, and there's a lot of work that's going on into how you go about bringing external people into evidence-informed decision making. And at the OECD, we did a lot of work with the countries trying to understand what works in terms of bringing scientific advice to sort of make the decision making more robust. And I think if you can look at the toolkit in correlation with sort of the lessons that we've all identified from COVID, and some of the sort of really discrete pointers of how you go about bringing scientific advice in emergencies, I think you would get a really strong sort of system that can actually give you a fighting chance at the next crisis. I'm not going to say you're going to be prepared, because as I said before, you have to be prepared to be unprepared, but at least it'll give you a fighting chance. And I think giving you a fighting chance is the least you could do for the people that are the most vulnerable, that will be hit the hardest, right?
Thank you. And did the other panelists want to comment, or should we go to the room? Yeah. Yeah. And one thing that we should say on the back of that is, what we should say about the pilots is that the observatory and the OECD were present at all of them. So we did have an element of an external voice in the room. So I know there was one gentleman who, oh, sorry, we don't. Yeah, sorry. My apologies. We don't have.
Thank you, Susie. You're such a friend. I love you. Did I tell you? We go so far. No. I discovered the Copenhagen thanks to Susie. Yeah, we need to be prepared, but I guess the key thing is at least we have to work to prepare ourselves. Period. Boris, as is from MSD, so I basically represent big pharma. So I hope you listen carefully to Alfonso about listening to the other viewpoint and learn from it eventually. I've been doing it, 20 years, learning from the other point. So first, I just want a couple of quick comments and a question. So first, this morning,
maybe the question to begin with.
Okay, all right. So it's about preparedness. So first, Professor Stoto, before SARS, you had anthrax, and anthrax was really the big turnaround in terms of preparedness. And that was in 2001, and that led to the creation of BARDA, in 2006. 2020, 2021, 2022, we had HERA, the Health Emergency Preparedness Response. So my question was, there's great cultural differences in any case between US and EU when you approach policy objectives and results oriented. But what do the panelists think about what has been the lessons from BARDA eventually, and what should HERA learn from those lessons?
Well, I could spend an hour on that, but I won't. But let me give you one just small story that's relevant to this. I think one of the challenges, as I mentioned in COVID, was scaling up testing at the outset, and we did particularly poorly at that in the United States. There's a really terrific paper written by two analysts at the US Food and Drug Administration about Korea, how they did that. And people say, well, Korea had MERS and they were experienced with this. But in fact, it was much more specific than that. They actually looked very carefully at their regulatory system for testing and how they could change that to work fast in an emergency. And they made those changes in advance. It made a big difference. Korea was one of the more successful countries, certainly in that respect of the outcome. So it's really thinking about what are the systems that are going to be necessary, and how do we change those systems in advance so they could deal with these issues. And that's just, again, one example of many that can be put forward.
Great. Thanks, Mike. Nathalie, you have a comment as well?
Yes, if I may, on
Please.
the European side of it, which is ERA, which was established in the European Commission. I don't know if there is anyone in the room working at ERA. So if not, I would allow myself also to respond to this question from that side. This health emergency responsiveness authority has been established in the wake of the COVID crisis, and it is a very interesting structure because we have seen during the COVID crisis that by reacting together, by working together, by being united in Europe, and I mean, trusting the European Commission for taking major initiatives, a number of things have come to maybe those member states who would have been the least best placed to have access to vaccines, to have access to masks. So this is a structure that was established when we were in a situation of crisis, but that will play a very important role for anticipating possible future crises and getting ourselves in the Commission and with the member states prepared. Another added value of working together, if I may say so. That was all I wanted to add. Thank you.
Thank you. Are there any other questions or comments from the floor? Anybody? Last chance. Okay, I think we had one question still from online. Is that right?
I think, John, we've probably run out of time, so we should probably move to the closing. Nestor, I know you're bursting, but there have been a lot of very, very positive questions, and particularly, Nathalie, to your sense of how the Commission works across DGs, how it is actually able to coordinate and to make those connections exactly as you were talking about, to make sure that member states are supported by the EU and are able to work collectively and together. So exactly what you were saying is very much coming up in the chat, and also questions about accountability. Know that we would like to have a photograph with this panel before we move to the very final session. So could we just take your picture, and then perhaps we really will go to the closing. Thank you very, very much indeed. The team like to be in the photograph? Let's go, quick. Yes, in the team, quickly. Go. Run. We have to go. And then I'm going to ask, because we're running very late, and that's probably my fault for not actually managing well at all with the opening session. But if we very quickly have a nice photo opportunity, Boris, I'm really sorry, but you can't be in the photo opportunity. I know you would be beautiful. You would be beautiful, but not. And then what we will do is just ask Giuseppe and Francesca to be 2 minutes. Oh, all of us. I come in as well. Giuseppe, I'm going to ask you to make a presentation of 1 minute and no more than 1 minute. Francesca has also promised me 1 minute is easy. Quick. Quick.
I'm never.
Thank you very much, and sorry to take time. Please, Francesca and Giuseppe, stay, but everybody else, thank you very much. Nestor, thank you very much. Mike, Nathalie, super, thank you. Gintaras, really appreciate it. Phil, John, thank you very, very much as well. Oh, yeah, I'm going to say you get to stay, and you as well. I think if we race through this large segment, then we will be virtually on time for lunch, which will be remarkable. And I'm going to come to you, Francesca, please, and ask you just for a few very few concluding.
I'll be incredibly short because it's very difficult to even summarize the richness of the discussion. And I think everybody's looking forward to the lunch. So first of all, obviously to thank all of you who stayed with us online and in person. I think it was an incredibly productive day, but it also shows that we have more work to do. And this toolkit and this handbook is something which is there to be used. So, I mean, that would be my first message. Just use the toolkit, use the handbook, use us. Joseph, myself, we're there, you know, our organizations, and I can speak hopefully for DG SANTE to really support countries in the implementation of this tool. And perhaps one thing that really came very strong here is that it's a tool not just for building resilience of a system, but really for the capacity building. And a lot of this capacity has to do also with thinking about the unthinkable in a way, or the things that we're not prepared, the ability to speak to those that you don't normally want or wish or think of speaking. A lot of perhaps humility also that we need to bring into that. And obviously being from OECD, we also think that there is a huge opportunity to work to build better indicators that will be helpful in this process as well. So looking forward to continue the conversations with you. And now over to you, Joseph.
Thank you. I'm sure Susie want me to hear my reflections of the whole day.
30 seconds or less, starting.
The time is getting shorter and shorter by the second. It's great to work with you, my deputy Susie. My deputy Susie, thank you. Seriously now, we learned a lot today, so thanks goes without saying. We learned that this very dry area actually is quite a lot of fun, is interesting, is possible. I think what we realized, and you were saying that the crisis is coming, we know the crisis is coming, and I hate to quote Donald Rumsfeld, but it's very appropriate. You know the unknown unknowns? The worry about the next crisis, we don't know what we don't know. So we don't this resilience in the basis that we know the unknowns, we know some of the unknowns, but we don't know what's coming. And the emphasis has been very much on process, or transformation, or learning. It's fascinating what we heard from the member states, how the process of doing resilience itself strengthens resilience. The transparency, the involvement of other sectors, data, stakeholders. So that's, I think, in itself, the way to go. Exactly, next message, Francesca, partner in crime. We, or rather our colleagues that know about it, are really ready to support you as member states, to work together with you, because the exercise itself can make a huge difference. And let me finish. I'm sorry, Susie, the Cinderella. I have to go back to my Cinderella. All of you heard me about the Cinderella. Cinderella is that Cinderella, male or female, who got to dance with the Minister of Finance during the crisis. Lots of money for health systems. Now she's back, he's back in the kitchen. The question that I want to highlight, echoing Sandra Gallina today, is that this stress test, which is independent, which is objective, independent, I think was Maggie was saying that, which is objective, which is uncomfortable to discuss, can help to get Cinderella back. This stress test can help the Ministry of Health to convince the Ministry of Finance to look for the Cinderella and find those kinds of resources. When you go to the Ministry of Finance and say, listen, this tool developed by the Commission with the support of the OECD and the Observatory is telling you this, and this. And if you don't put money, be ready about the problems of sustainability, security, cohesion. I think that can make a difference and bring the funds that we so much need. So I'm very excited today about this. I think the stress test is much more than stress test, an opportunity to bring back the health system and show how the health system can support other sectors, and indeed other sectors to health. Thank you.
Thank you both very much. Thank you so much to all the panelists who came, Liliana, Gintaras, everybody, and Phil and John and Marina for all of your facilitating. Lunch is served.